Madam Secretary, next item, please.
Item 3 is a report with possible action on near-site employee clinics. This is an informational item, and although it has been noticed for possible action, no action is required.
Superintendent Driver.
Chair Bonds will be right with you. We're just waiting for the team from Hayes to come out to the stage. I don't think they can hear.
Superintendent Driver, are y'all ready? Oh.
Okay. Yes, Chair Bonds, we are.
And Madam Secretary, Superintendent Driver, I apologize. Just for the audience and my colleagues, I intentionally had this item come before the other items because the other items may impact this item. So when you, so there was a reason I put it in these sequence, and this is only looking for permission to explore that option. It's not actually adopting anything because to pay for this would depend on what we do on the next item. So everybody understand, and this is just exploratory, and it will be impacted by what the board does on the next few items. Okay, given that, Superintendent Driver.
Okay. Thank you, Chair Bonds, members of the committee. This evening we have several presentations that focus on personnel and proposed benefit changes. Thank you, Chair Bonds, for the introduction. For some time, we've been discussing the potential benefits and savings of implementing a near-site employee clinic for our MPS employees. Such an option would assist in addressing health care costs and maintaining quality services for our staff. I'm joined this evening by our Chief of Human Resources, Himanshu Parikh, along with Carol Eady, our Director of Benefits and Compensation, along with consultants from Hayes, who's going to share a detailed presentation and giving a conceptual overview of this model, the necessary data, and potential next steps. So with that, I'll turn it over to the team. Thank you.
Chairman Bonds, members of the committee, Himanshu Parikh, Chief Human Resources Officer. District had previously reviewed the options for on-site clinic as a way to make healthcare more accessible and more affordable for the district staff and their families. To build on-site clinics, it would require a large capital outlay upfront as well as ongoing servicing costs. Given the short-term and the long-term financial projections for the district, that is not a viable and fiscally responsible option at this time. Instead, we seek your permission to review the option of exploring near-site clinics. Near-site clinics which would have lower capital requirements, and we would opt to partner with clinics already operating in City of Milwaukee. At this time, I would like to introduce Ms. Amy Cole and Mr. Michael Newberger from Hayes Companies, District Benefit Consultants, to present the option of the near-site clinic. Thank you.
Thank you. Thank you and good evening. As Matthew mentioned, my name is Mike Newberger from Hayes Companies. Amy Cole is joining me here from our office. We're going to walk through a discovery presentation on the potential for near-site clinics for MPS employees and their dependents. In the presentation, we're going to walk through proposed or identified services that would take place within the near-site clinic. We're going to talk through potential providers and access maps as to where your employees live and where they're working. Discuss some key success factors. Walk through estimated cost-benefit analysis, and then discuss next steps if we were to proceed with this. So, let me go one more. So with respect to the near-site clinics, as Himanshu mentioned earlier, these are not an on-site clinic, they are more near-site clinics. And the idea here is that we would partner with a provider system who already has clinics in the Milwaukee area and would then have access to those clinics for the employees of MPS. The proposed or identified services talks through the fact that we'd want to look at multiple clinics that cover the current MPS geography. So the intent here is to look at, would it be reasonable to have 1 clinic available, 2 clinics, 4 clinics, 6 clinics? What is the right mix of clinics for the employees within MPS? We'd also want to look at expanded hours to make this available to employees. In other words, before and after school to make sure that it accommodates the full staff. Additionally, would we want to have Saturday hours or even Sunday hours for the MPS employees and their dependents? The identified clinic services would be preventive type services, exams, acute services, diagnostic, laboratory services, etc. We'd also would consider potentially having an RX dispensary that would either be through that provider system that we partner with or through the medical plan through Optum, who is the pharmacy benefit manager. Delivering those services to the employees would be a nurse practitioner. Within that realm, that nurse practitioner would then also refer employees to perhaps specialized services within that provider system. The rate structure for the near-site clinic would be based off of a $20 copayment per visit. Along with that, the suggestion would be to adjust the medical plan and increase the copays within the medical plan. So for example, the primary care plan currently has an office visit of $20. The suggestion would be to go to $35. Specialist and urgent care is currently at $35, would go to $50. Emergency room copays currently for the PPO plan are $150, and for the EPO plan are $125. The suggestion would be to go to $175. And then preventive care would remain at a 0 copay. The reason why these copays in the medical plan would be suggested to be increased is that you want to have leverage to encourage people to use these near-site clinics. As we walk through how this is paid for.
Hey, excuse me, I'm going to respectfully ask people to keep the noise down during the presentation. If people continue to disrupt, I will ask security to escort people out. Continue.
Thank you. As we walk through the services, we would be paying a fee to this provider system, regardless if employees were using it. So it's important that we make sure that employees are encouraged to go through to that near-site clinic. Otherwise, we'd be losing money because of the fact that we're paying a fixed cost for the access to that clinic, but yet if no one uses it, we wouldn't be able to get the savings out of it. Additionally, the high deductible health plan, that cost would need to be based upon market conditions. That is a Department of Labor requirement, and therefore the copay for the high deductible health plan would need to be determined at a later date. As I said, the balance then for these services, the employee is paying the $20 copayment for that near-site clinic. The balance of those services would be paid by MPS, and I'll walk through that in just a minute when we talk through the cost-benefit analysis. The potential outcomes, why would providers want to partner with MPS in this type of program? Well, first of all, if we have the increase in the copays in the medical plan, and we now have a lower cost item, i.e. $20 from that near-site clinic, you will have steerage or people using that near-site clinic because it will be more affordable for employees to go to that near-site clinic. Additionally, the near-site, the provider system would also most likely get referrals within their system. In other words, if we select a provider system such as perhaps Aurora within the area here, if Aurora's nurse practitioner is servicing the employees of MPS, if there are requirements for specialists to be involved, such as an orthopedic surgeon or what have you, the referral would probably be to an Aurora specialist. So that provider system would want to be involved in this and hopefully come through with aggressive pricing for this near-site clinic. So some of the potential identified partners that we'd have would be providers that have a presence in the Milwaukee area. And those would be Ascension, and you can see the providers that are listed under the Ascension brand, Aurora, as I mentioned earlier, and then Freighter Healthcare. We have had preliminary discussions with these provider systems, and they shared with us, a few of them shared with us, some access maps based upon where their clinics are located in the Milwaukee area, and then accordingly, where are employees of MPS located in this first example via their home zip code. So the legend, and it's hard to read a little bit from the audience perspective, but the legend notes that the triangle is where the Aurora clinics are throughout that Milwaukee area. And then you have a heat map that shows where the employees are located by zip code. So then you can see in the dark blue is where a majority of the employees are located. Then as the color gets to lighter blue, green, yellow, and then red is where you have less employees. But you can see obviously based upon home zip code, the majority of those employees are located right in the middle of the Milwaukee area, and there are a number of Aurora clinics there. So that would be obviously a viable option for employees. The next map looks at employees' work zip code. Same premise where we have Aurora with their triangles and their clinics, but then we list out where employees are located via their work zip code or where the schools are located by zip code. Same premise with the map on the bottom. Dark blue is where the majority is located, then blue, then green, then yellow, then red. So again, what we're trying to do here is just do some discovery with these potential partners to find out, is this going to be a viable option for MPS to consider? Freighter also replied with an access map. Their coding is just a little bit different. In fact, it's the opposite of what Aurora did. If you look in the legend, on the left-hand side, you can see this is by home zip. And their legend notes that their clinics are either in red, a circle, which is blue, purple, red, green. And then again, the zip codes are mapped out by the heat map. The majority of the people then are located in the darker red, and then as it goes to orange, yellow, et cetera, is where the lower volume of employees are located via their home zip code. On the right-hand side is just the opposite as we talked about with, now it's looking at the employment zip code for those employees, okay? Freighter did go into a little bit more information on specifically the number of employees by zip code. I'm not going to walk through that here tonight, but we do have the ability to walk through that detail and look at where or what the number of employees are in a given Milwaukee zip code. So what are some of the key success factors for this near-site clinic? First of all, obviously the cost of the clinic, and I'll walk through this in a little bit in a very high-level manner in a minute when we look at the cost-benefit analysis, the savings potential, the redirection of services to that near-site provider, specifically when we look at the plan design leverage that we talked about earlier. In order to encourage people to go to that near-site clinic, if we make adjustments to the medical plan by increasing those copays as we discussed, and you still offer an option of a $20 copayment, that is hopefully the direction that would be needed to get people to use the clinics. The hours of operation obviously are important. Suggested hours would be perhaps 7 to 11 in the morning and then 2 to 6 p.m. in the evening. We haven't listed out the Saturday or Sunday hours, and we'd want to talk more to the provider partners as to what would work best. Additionally, we haven't talked about the ability to perform pre-employment physicals, but that could also be an area where we can steer services through those near-site clinics. Clinic flexibility, this is an important key success factor. The idea or the concept here is that we would not just have one clinic available to employees, we'd have multiple clinics available. As you saw, for example, Aurora had many clinics available in that Milwaukee area, as did Freighter. The idea here is that we would select, for example, perhaps 4 clinics. strategically located throughout the area. But if we find that after perhaps 3 months or 6 months, one clinic does not have a lot of utilization, we want the ability to adjust and perhaps select another clinic where we could get better utilization. So the ability for that provider to offer flexibility in opening or closing a given near-site clinic based upon utilization patterns of MPS, that will be very important. And then lastly, appointment scheduling. If the clinic is to be used, we obviously want to make it easy for employees to have access to that. So perhaps appointments via a mobile app, appointments via the web, what have you. We want to make sure that it's easy to make an appointment to see the provider at that near-site clinic. So cost-benefit analysis is next. I have 3 pages of information here. The first 2 pages is very detailed information on how we're estimating the cost-benefit analysis. Remember, though, that this is a very high-level review of this and is contingent upon specific responses via an RFP process from those providers. This first page looks at the cost of the clinics, and as you can see, we're modeling out options of either 1 clinic, 2 clinics, 4 clinics, 6 clinics. We're listing out what the potential cost could be for that. In the upper left-hand corner, we're noting that to have these services run through the near-site clinic, we'd want to have a nurse practitioner who would offer those services, an estimated cost of $95 per hour. You'd also probably want 1 administrative coordinator at each clinic at perhaps $20 an hour. We work that math through on those modeling options of the 1, 2, and 4 clinics. We get a certain cost number for that. The next page talks about the benefit. Again, I'm going to stay high level and walking through what we have here. But the idea here is that services that are performed through the medical plan right now, a number of those services obviously would go through the near-site clinic at a lower cost, and that's where we'd get the savings for this. So what we did is we modeled out the number of services that are currently being paid via an office visit and an urgent care and emergency room visit, and then looked at what the paid amount is that MPS is paying right now through the medical plan. We then walked through scenarios on the far right-hand side that looked at what happens if we get 10% of the office visits to now go through the near-site clinic as opposed to the medical plan. Additionally, what happens if we get 5% of the urgent care or emergency room visits to go through the near-site clinic? We did that also for an example of the far right-hand column of perhaps 15% of the office visits and then 5% of the urgent care and the ER visits. I'll walk through what those numbers mean on the next page. So a summary of what I just talked through is the top half talks about excuse me, the cost for this clinic or for these near-site clinics. And the assumption is that we would have a nurse practitioner, administrative coordinator at $95 per hour and $20 per hour, 4 clinics at $40 per hour or 40 hours per week. That would equal a total estimated annual cost of $950,000. The benefit or the savings would be using the example where we have just 10% of the office visits go to that near-site clinic and 5% of the urgent care and the emergency room visits go through that near-site clinic. Total estimated savings of that is about $1.65 million. You subtract those numbers off of each other or you compare them off of each other, equals an estimated annual net savings of $700,000. Now take note that whenever an employer implements an on-site clinic or a near-site clinic, that initial first year, you don't have as much of volume running through that near-site clinic or on-site clinic. So these estimates would be based upon when that clinic gets rolling and there's full utilization going through the near-site clinics. So that first year, you may not see the actual $700,000 in savings because we may not get that many people or the proper amount of people running through that near-site clinic. The disclaimers at the bottom, I just wanted to walk through. Other areas of savings that could be seen or realized within this near-site clinic could come from some lab services that may run through there. We didn't look at that in our analysis. Also prescription drug services that could go through there. We didn't look at that in our analysis. And then the last one there is health coaching. And this one is somewhat of a soft savings, but when you think through what takes place now when you're going through a doctor, typically you have about 5 minutes to talk to that doctor in a normal traditional office setting. In a near-site clinic, the concept is that you have more time to spend with that doctor or nurse practitioner, so that as you're going in and talking to that nurse practitioner about a given ailment as to why you're going in and talking to them, perhaps respiratory condition or what have you, that nurse practitioner can also then talk to you about perhaps, oh, you're a diabetic. Have you been doing and have you been taking or having your A1C test done throughout the year? How is your diet going? So that the idea is that that individual is not only being treated for the service that they went in for, but then also for health coaching for potential other issues that might be with that individual. Other areas of cost that could come in from this is that you could have additional services because of the convenience factor of where these near-site clinics are located. So an individual who may not go to the doctor in any given situation may go to that near-site clinic because it is right down the road from where they're at and convenient. So that needs to be considered. Additionally, there is a steerage factor to that physician system that we need to make sure we realize also. As you're going in and seeing that nurse practitioner, they may want to refer you into a specialist more often than not in a given situation. So there could be added cost there for those types of specialty types of situations. And then the last disclaimer at the very bottom talks about, remember, this is a high-level review of potential costs and savings. These estimates should not be used in budgeting or other financial estimates. A full RFP is needed to determine the estimates of cost and savings potential. So the next steps. First of all, we'd want to seek board approval. If the board does approve to move forward outside of this discovery phase, go to request for a proposal where we seek out provider systems, but then also open it up obviously to other entities who think or believe they could offer this type of service to the MPS population. Go through that process and select a vendor, then develop a communication plan for employees, which is critical to the success of this, because again, if we're paying an hourly rate for the nurse practitioner and that coordinator, that's a fixed cost that we'd be incurring as a district. We need to make sure that people are using those services and we get the savings potential realized that we talked about earlier. So that communication plan needs to be in-depth and sent out to all employees and their dependents. The intent then is to have these near-site clinics open effective January 1, 2019. That would be dependent upon the flow of that RFP process and then, of course, input from the physician partners that we would be talking to.
If that individual speak out again, I will ask security to move out right away. Continue with your presentation. Let me pause. Once again, we're dealing with some important issues tonight, and we owe it to everyone to hear all their pros and cons. And as chair of this committee, I'm not going to tolerate any disruption. And as people break out, I'm going to request security move them out right away. Continue.
Thank you, Walt. That actually concludes my presentation on the near-site clinic.
Okay, there's no objection from my colleagues. I would like to open up to the speaker slips, if there's no objection to the committee member. President Singh.
Yes, Mr. Chair, I noticed that there are some of our speakers who are with children, and if we can maybe suggest that those individuals come first, if no objections.
Mr. Chair, it's only a few that actually want to speak, so if there's no objection. I had, just for the audience and the listening audience, I have 99 non-speaker slips, and I got about 19 speaker slips. And because I have 19 speaker slips, when the red light come on, I would respectfully ask everyone to stop talking so that other people can have opportunity to share their views too. And I will ask the board clerk, once the red light come on, to cut it off. Okay, the first speaker, Ryan Thompson. Do you have a Ryan Thompson? Followed by Maureen Kerrigan. I can't read this. It looked like a P and then a K something. I can't read this small print. Okay, the first speaker, Mr. Thompson, welcome. Feel free to start and give your last name for the record.
Ryan Thompson, Thompson. I'm a teacher at Goldmeyer High School, and I would like to recommend that all of you vote no on the proposal for whatever the near-site clinics, we value being able to choose our own doctors. We value having our healthcare decisions in the hands of people that we have learned to trust with our medical advice. And I would strongly suggest that everyone votes no for the near-site clinics. I believe the estimated $700,000 in savings could certainly be offset if the raises for administration were rescinded. I believe some of that money could be recuperated by not paying for mandatory mindfulness training. And I believe there's plenty of other fat that can be trimmed out of this budget other than telling us where we need to go get medical advice. Thank you very much.
Maureen Carrington, and once again, it's three. I asked my colleague and the board clerk staff, and we still can't figure out this last name. Is P. It looked like a K-U, and it looked like the address what I was spelling is on Colgate or something like that. So I wanted the person to have a chance to speak, but we just can't figure out the writing. Three of us had to look at it. In the meantime, Maureen Carrington, if you can come, and I would ask that, just like Mr. Thompson, just talk on the item, the near site cleaners. Maureen Kerrigan? Okay. I'm going to try it. It got P. Kula, K-U-L-U-L-A. Is that it? We've been trying to figure out the print. Okay. I'm going to go to the next list then. Maria Jenkins. Is there Maria Jenkins? Maria Jenkins? Christine Mahler, M-A-H-L-E-R. Okay, don't have that one. Kathy Geiger, is there Kathy's here? Okay. Oh, okay. Kathy Geiger, followed by Matt Stark. Kathy Geiger, Matt Stark, and Julie Holzer.
Mr. Chair?
Yes.
Given that we do have overflow in rooms 210, 211, as well as the cafeteria, it may take a moment for the speaker to get here. So if we could run.
Okay.
So if we could repeat the names after the current group of speakers.
That's fine.
Thank you.
Welcome, Ms. Geiger.
Thank you. Kathy Geiger, G-E-I-G-E-R. I would vote no for this. These near-site employee clinics seem to be duplicating what we are already offered. We have a choice of walk-in clinics through our network's PPO or EPO. Why would you bother to set up your own company store health clinic? It seems like a waste of time and money paid out to more consultants. And for only a net savings of $700,000, really. Also, please keep in mind that disclaimer that these estimates shouldn't be used in budgeting or financial estimates, as that's what all this is about. If you really want to lower the healthcare costs, give teachers back their time. Reduce their stress. Since 2013, administration has dictated how teachers spend the extra 8th hour per day. Along with that, and more duties have been heaped on, data
Ms.
to
Geiger,
enter.
Ms. Geiger, can you get back to the,
I am.
item?
It will relate. It will relate. It will relate.
okay.
Claiming my
You're allowed
time.
in and you're out of here. Go ahead, Ms. Geiger.
Heaping on more duties, document this, intervention that, board police visits, never-ending stress. Luckily, I'm retired and I'm able to peruse the teachers' Facebook group, and it's distressing to read of teachers having numerous anxiety attacks, and many have started counseling and/or medication. This is how stressful this job is, and you are causing so much unnecessary stress that is unwarranted. Let teachers teach again. Only 2 hours of administrative meeting per month. It would not cost you a thing to remove that stress and give them back their sanity. And this would
Ms.
lower your
Geiger, cut
health care costs and your
Cut off,
substitute
Ms.
costs.
Mann, Dr. Mann. Thank you. Once again, I'm going to call out a few names, and these individuals was downstairs. I call them Maureen Kerrigan. Okay. Christine Mahler. Okay. Matt Stark. Do we have Matt Stark? Okay. Dooley Holzer. Debbie, it looked like Ashaw, is Debbie, okay. Amanda, it looked like Vogel, V-O-G-E-L, Amanda, we had a person. Ben Word, is there a Ben Word? Okay. Welcome, Mr. Ward.
Good evening. Ben Ward, W-A-R-D. I'm the Mta Executive Director. I urge the committee to vote no. The near-site clinics were originally presented in Meet and Confer as a way to avoid urgent care costs. As you can see from this presentation, there's not a major shift in urgent care costs. This actually deters employees from their primary care providers with copay steerage for primary care going from $20 to $35. There is no continuity of care. You're going to see a different NP every time. The scheme is dependent on massive copay increases to employees, $700,000 in savings, and you'll see shortly, as Director Bonds referred to, that it will cost $4.3 million in copays, savings to the district, costs to our educators. This has been a bait and switch, and I would also ask the committee to explore how much was spent on the consultants. I'm here to speak on behalf of the men and women who work for this district. No cuts to schools, time, health, and a raise.
Amanda Vogel, he called me downstairs.
Okay.
So,
Spell your last name for the public.
E-O-G-E-O. I'm representing Riverside University High School and every other teacher in this district. So I am a third-year teacher. I always tell my kids I was born at Riverside, I will die at Riverside. Student taught there, I will teach there until I'm dead, which will be next year. Where do you go to the doctor?
Well, let's stick to the item. I'm not going
That's
to.
my question. But you're telling me where I get to go.
I haven't told you anything. This is a proposal from the administration. Either speak to the item or get away from the podium. Either speak to the item or get away from this podium.
But the item is a proposed
Cut off.
directive
Unless
on
you're
where
gonna talk to the item,
where
unless you
teachers
talk
are
to the
allowed
item.
to go
If you're
to
gonna talk
seek
to the
health
item,
care.
talk to the item or either, okay, talk to the item then. Okay. Talk to the item.
Because they don't want to hear me talk. Oh, I'll raise my voice. So, you don't, I mean, it's a proposal. I get that. It's an idea. A bad one. We're on a show every day. I always tell my kids, I'm putting on a play. Every day, I'm up on the stage. I'm giving you 110%.
Excuse me, Ms. Vogel.
And you
direct
get to
all
leave,
comments to the chair.
you and my kids leave the room having seen a show. But the show takes a tax on the performer. And now you are telling me, well, we're going to set up these real quick fix. It's a Band-Aid on a bullet hole. You give us the insurance, and now you're going to tell us where we have to go. So we're going to take your money for your insurance, and we're going to take it and put it in our pocket for our health care that we're deciding where we want to go. My physician, my body, my health. This proposal is, well, how much did you spend on this consultant? Did you ask any of the thousands of teachers you have in the district? Where was our say? Where did a survey lets you direct it to the audience? Hey, teachers over at Wedgwood. Hey, teachers over at Riverside. King, where do you guys go seek medical care? You don't care, period. And that seems to be a problem. We're supposed to care 100% of the day for our kids. Well, guess what? We're your kids. Take care of us. I'm going to say this is a bad idea. Move on to the next idea. Try harder. Do better. That's what I tell my kids. There's always tomorrow. Fix it.
Hello, Director Bonds. I think you called my name, Debbie, S-E-H-U-L-Z.
I'm sorry, what's your name?
Debbie Schultz,
Yeah, pardon.
S-C-H-U-L-Z. Okay, I am here not just representing I'm here representing all the paras. And this is coming from my heart. I had 4 doctor tests that he wanted to do on me. And I'm going to tell you right now, with what we make in 1 year, my deductible to meet my co-pays and my payments, not including office calls, comes up to $1,700, $1,750. So what you're proposing is on my $45,000 a year that I'm making on my job, I should pay out another, $2,500 to try and take care of myself from, I agree, the stress that is put on us because of the things that we have to deal with the children. I think that I am just as important as every single child that is in MPS. And I say no to this. I want my doctor that I have at my age to know me and to take care of me. Thank you.
Thank you. Is there anyone else who I called that might have been downstairs? I think we got one additional person. Security is showing me somebody who. Okay. And once again, I called this individual earlier, so come on over and speak.
Evening, everyone. My name is Petra Kenny. I'm sorry if I have terrible handwriting. You can read my name. That's
yep,
not me.
It's pretty bad. I thought mine was bad.
I was writing real quick. There's no pens. So I just want to get a little personal here for a second. When I was 16, actually, I work at Coggle Elementary. I'm a second grade bilingual teacher. I started.
Excuse me, could you please spell your last name for the record?
A-E-N-N-Y.
Thank you.
This is my second year in MPS. Going on 3rd year next year. I started a soccer team there myself last year. We continue to have success. But I just want to speak to my personal story here. When I was 16, I have a brother with Down syndrome. He had epileptic seizures, and he passed away in my backyard. He drowned in our backyard pool. When I was 20 years old, my father hung himself when I was away at college. That same summer, my best friend, the father of my niece, died in a car accident. All my safety net went away. My mother's a teacher at Hampton. I'm a teacher at Coggle. And I just don't know how you expect me as a young individual and educator, a passionate person, to make a career being an educator. With my pay, there's no pay increases. teacher, I make less money because of cuts to my benefits. Cost of living increases.
Mr. Kennedy, can you bring it back to the near site, just consistency?
That's just another ploy by this committee and this board to put it on the back of us true workers, the educators. We're the ones in the front lines. We are the ones who do the work in this district. We should be top of the totem pole.
I'm going to ask you one more time to tie it to the item.
I'm sorry, what?
Please tie it to the item, or else I'm going to have to have you cut off, so please tie the item to the near site.
Our benefits doing that.
Okay.
That's exactly what you're doing there. I should have the right to choose my doctor. I went to school for 8 years. I should have been 10. I graduated 2 years early. And you're telling me I'm not smart enough to pick my doctor? I mean, are you kidding me? Enough is enough. You need to pay us. You need to...
Doesn't save money. Do some research. And thirdly, please do not divorce me from my husband. Thank you.
Before I go to the committee members, are there anyone else whose name been called needs to come up? Anyone else? Okay, once again, we got 99 slips that where individuals didn't want to speak, and we have about 21 speaker slips. At this time, I want to pass it over to committee members. Are there committee members? And also, please note that Director Voss and Director Harris has joined the committee. Director Falk.
Thank you. I taught in Milwaukee Public Schools for 31 and a half years. I was on the executive board of the MTA for 12 years. This is a difficult job, and I appreciate what you're doing. But we have to, here's the reality, ladies and gentlemen. This year, we have a $38 million deficit that we have to bridge. Next year, we will have a $78 million deficit. The year after that, a $119 million deficit. In 2020, a $149 million deficit. And in 23, $177 million deficit. We will be bankrupt in about a year and a half. In a year and a half, we can bridge maybe a little bit, but after that, we will be closing schools, we will be laying off teachers, and we will be cutting wages and benefits in order to survive. And in the third year, we can't survive. Now, I want you to understand when we're looking at health care costs, we're trying to figure out every way we can to bridge that gap. And you got to help us out figuring out a way of doing it. Because we're not going to be in business in 2.5 years from now.
Okay, before we go back, just some clarification for the administration. I want to make sure these numbers are right. So, because part of this proposal is to save money because there's a proposed 5% cut in classroom. Is that accurate?
Chair Bonds, members of the committee, the changes that we're proposing in total tonight, it's bigger than just 1 year. So yes, this year we are looking at cuts for central office as well as for schools. We're also looking at the years coming. What Director Falk stated is part of why we're bringing so many things at once. So yes.
I understand it, but it's a 5% cut because the numbers I got, just so we have this in a general context, the 5% cut is the equivalent of $11 million. Is that accurate?
The 5% cut for schools is 11.3, and the 15% for central office is 11.8.
Thank you. Director Phillips.
Thank you, Chair Bonds. I just wanted to ask a little bit more. I know this is an informational item, and from my understanding, no action is required, correct? So for information, it seems like, from my understanding, when I first learned about this model, it was an additional resource opposed to replacing existing healthcare. So Questions that I have are around this idea of this model. Would this take people away from their primary care provider, or is it just an extra choice? Second question that I have is this idea of continuing care. So I know there are times where I've been sick and I don't know what I have, so it's easier for me to go to urgent care versus waiting 3 days to see my doctor. But they still have to be able to contact my doctor. So in terms of continuing of care, is this model trying to drive people to a specific network that the clinicians are providing? Or if I belong to Ascension and this clinic is run by another provider, does that change who my provider needs to be? Third, something that I thought was appealing about something like this was the idea that there wouldn't be copays and that it would actually help me get care when I wouldn't have before. So I was a little surprised to see copays being part of this model, because that was a real draw for me, because I'm very interested in finding ways that we can close the gap in care, making sure that we have more options, that people aren't waiting to see their doctor because they can't get in. But if this is limiting the availability of care for people, I think that's very troubling. And also, and just clarification too, this is something that would be available to the entire district. So this isn't solely based on school-based staff versus it's the entire district. Okay, so I know I just asked I think I said I was asking a few, and I think I asked 8 questions. So if you could provide a little bit of clarity around, mostly for what I'm interested in is whether this is an informational item. I appreciate that we're trying to find ways to close the gap in care, but I'm troubled with the idea that this is taking away choices. So that I think is what I'm trying to say. It's a little warm in here, so.
Superintendent Driver, would the administration like to respond?
Chairman Barnes, Director Phillips, members of the committee, I think the first question was, is this an extra choice? And that is correct. The current health plan stays in place. There's still an option to use the current health plan. It is one of the options to go to the near-site clinic. Thank you. It's one of the options to go to the near-site clinic. The idea of the near-site clinic is to give ready access to the employees and not have to wait for a day or two to make appointments. Hopefully we can get the employees to the nurse practitioners as soon as possible. As far as the care goes, this would not require them to change the care or their career in any respect. They can still go to the career they like. If they would like to go to the nurse practitioner, they can. It is again an option and not a requirement. And they can choose whatever career they like under our EPO or our PPO plans or the high deductible plans we currently districts have. So we are not by any means trying to change the providers for the employee's choice. With regards to the copay, the district is requesting a copay so that we would have the utilization of the clinics in a more fair way. But if we decide to not charge clinics, we can look at charge copay for the clinics. We can look into that model also. These are the thoughts for RFP. We are not proposing anything at this point and going through thought process, and that's what we like to get the input, and we appreciate that. The next was the limiting care. Again, there's no limit to the care. They'll get full access to the provider of their choice within the plans that we provide. And then the entire district, this plan provides for all employees and their dependents and all pre-65 retirees. Anybody who is on Medicare on a fully insured plan and would not have access to the near-site clinics, but everybody else would have access to the clinics. So it does provide access to everyone, employee and their family. Thank you.
Vice President Miller.
Okay, people can put some blame on me for bringing this idea forward. In the last 4, maybe 5 years, I've visited Green Bay, seen their clinic. I've been to Hartford, seen their clinic, been to Lake Geneva, seen their clinic. Actually, in each of those visits, it was during clinic times, and I never saw a patient. But the stories that they gave me were valuable. I guess my problem was I was being very idealistic and seeing that the weight of this, it was necessary to change the copay structure and the contribution to the premiums. And that's a deep concern to me at this time. I think we are going to have to do some serious changes to our health care. We have to find ways to save money. We do have a serious deficit, and I don't think people are quite getting that yet, but it's very serious. If you read the facilities plan, for example, the executive summary, you get a real sense of where things are going over the next number of years. But I'd like to ask the administration, so if someone is giving birth, how do they, what are the extra costs in a situation like this, which I encourage children, and I want working families to be able to have children and to be able to afford children. I know of cases where I've had teachers come to me under the present system and complain about how it's very difficult and costly to have children. Could you run that down for me, just giving birth, what that would entail under this system?
Director Barnes, Vice President Miller, and members of the committee, the question, if I understand correct, how would it impact somebody who's expecting a child? The cost to them would be probably, if we look into increasing copays, it would increase the copay, but this does not increase the deductibles or the out-of-pocket max. So I would assume somebody who's expecting a child might reach the out-of-pocket max for the year in which they're expecting, and this plan does not increase out-of-pocket max for the plan.
So just a follow-up, Director Barnes.
Vice President.
So for each of the doctor visits, which we encourage a lot of them, it would be a $35 deductible to go to their doctor, because I'm not going to send my daughter to or my son's wife to the clinic. I mean, I know these nurses are totally capable and do a lot of the work at doctors' offices, but it would be a $35 copay, and if there's any specialty, it would be $50.
Yes. Just a point of clarification, this is an optional clinic and not a required. And as far as the copay goes, the copay that is correct is more, but generally there is a flat fee or a global charged by hospitals for the delivery of a child or for the child itself, and it's and for the prenatal care. So there's a global charge, and most of the times the out-of-pocket max is reached in that process. So probably out-of-pocket max for that year would still be the same. I would assume whether we pay a $20 copay or a $35 copay.
Thank you.
Okay, I got Director Falk, followed by President Singh.
Just so everyone knows, the only person up on stage here that's delivered babies is our President Singh. The point is, Green Bay, I did visit it along with Vice President Miller. And in addition to visiting the clinic and the central administration there, we also visited the Green Bay Education Association office, and they did support their clinic. Now, I want to point out the devil may be in the details in terms of this, but you will see around the country people supporting, labor unions supporting clinics, and some of it might be based upon how they are set up. A couple of things also to understand. For example, I just this week, I have type 2 diabetes. I went and saw my doctor this week. I can maintain my doctor who is managing that, but there's no reason on just a general checkup on that diabetes that I have to see the doctor. I mean, I can go to the clinic, that information is electronically sent to the doctor, and he can get back to me. So the point is, as I mentioned before, we have a big hole on our budget. We're going to be looking at a lot of other things right now. And I understand that, you know, you're saying, well, it's less than $1 million, but, you know, we're going to be in a situation, ladies and gentlemen, we got to find the money to run this district, and I don't know where we're going to find it.
Okay, I got Vice President Sane. I'm sorry, I demoted Vice President Sane. I got distracted by the gentleman coming down. Was she one of the speakers? What's your name?
My name is John Thielman.
Okay, you wasn't on the speaker slip. So
I have for a different item, which I'm willing to give up.
No, it doesn't operate that way. Madam Secretary, let me finish explaining. If there's no objection, if you want to speak on this item after my colleagues speak out and you fill out a form, you can come back and speak. Okay? And once again, I want everybody to have a chance to speak, but once again, I'll ask people to keep the noise down because these are some very important issues we're discussing. Okay, back to the speaker. President Saying, I'm going to give you a motion back.
Thanks, Mr. Chair. Just a few questions for administration. The first one's for clarity. We talked about the $700,000. That's if the plan starts in January of 19. That's correct? We'd be looking at a $700,000 savings?
President saying, members of the committee, $700,000 is for a full year. So for half a year, when the plan starting January 1, 2019, for fiscal year 18-19, it would be approximately $350,000. At this point, we are saying that it will be cost neutral because it's the first year, and based on the utilization, we won't be able to find out if there's been any savings in year one. But we are looking at the full year savings, like a full 12-month savings is $700,000.
All right, and then my
Follow up, Mr. President.
Yep. Thank you, Mr. Chair. And so my next question is, does this proposal take an employee's doctor away from them?
It does not take away employee's doctor away from them. It is only an option.
Okay. And then my last question is the position of a nurse practitioner. Can you give us an idea of what their education level is? I think when some folks hear the word nurse, there's, you know, I guess a level of expectancy as far as medical care is concerned. So can you just give us an idea of what a nurse practitioner brings to the table?
President, I'm going to refer this question to Mr. Michael Newberger.
Yes, the nurse.
Please, for the public record, yes.
All right. The nurse practitioner, I'm sorry, Michael Newberger.
Thank you.
The nurse practitioner is a registered nurse who has received additional education and clinical training, usually obtaining a master's degree. Similar to an RN and a physician assistant, they work under the supervision of a medical doctor, but work independently within that setting. They can diagnose and treat diseases and write prescriptions, and they can do about 60 to 80% of their work involved in 60 to 80% of their work is involved in primary and preventive care.
So just to follow up, Mr. Chair, so it's not like you're going to go see a nurse. You're at a much higher level and maybe just a couple of educational hours underneath doctor?
They haven't gone through the residency and so forth.
Right.
So they're not at that medical doctor level, but they have that extensive training and education, both additionally in the clinical areas to help treat and diagnose conditions. They're very involved in on-site clinics. That's where a lot of the services go through is the nurse practitioner.
Sure. All right. Thank you.
Okay. Do I have other committee members wish to speak? Any other comments by committee member? I got Vice President Miller, Director Voss. Vice President Miller.
I'll defer to Director Voss.
Director Voss.
Thank you for allowing me to ask some questions. I'm not a member of the committee, but I definitely thought that these items were important enough to come and listen to the community as well as the administration. So my question is for the administration then, Chair Bonds.
a couple of questions. Have you ever considered modeling this system with a free, no copay whatsoever with respect to this model, or a $10 copay? Because it seems to me, if I'm understanding this correctly, that we have a cost regardless of what the copay is with respect to this model. And so therefore, if we can offer either no copay or $10 copay, there must be some additional savings with respect to that, because you're still driving behavior if people go to urgent care. So I'm sorry, true confession, I'm very guilty of being an urgent care user with my kids. If I know they're sick, the fastest way I can get in is urgent care. And I do that fairly regularly, and it's really close to my house with this particular urgent care clinic, right? And so, and what happens in the urgent care clinic is that I inevitably am seeing a nurse practitioner. And so this is a very common experience for me, but I'm trying to figure out how, if we have a consistent cost, regardless of the copay use for this, if there's a benefit to, let's consider less on the copay, and because we know we're paying a certain amount anyways. So what, is it a negligible cost? Could they handle additional, if folks start using it like crazy, you know, is there still a scale up option or not? And I guess that's a question to, like, have you looked at other models with respect to this particular copay with this particular clinic idea? Mr. Parikh. Or, yeah.
Go ahead. Chairman Barnes, Director Wass, and members of the committee. Mr.
Parikh, once again,
thank you. Himanshu Parikh, Chief Human Resources Officer. The purpose of this report was to explore options, so we can definitely look into more options as to a free option and a $10 copay option.
Okay, and then
insurance, and will not be allowed to have those negotiated rates that we have right now.
Okay, so that's not an option.
It would not be a viable option.
Okay, and then one last question, if you don't mind.
Are there... Director Walls, before you go on, once again, I would respectfully ask all speakers to identify themselves for the public record and the listening audience.
Thank
Director
you.
Walls.
Chair Bond, are there specific examples, and I don't think I missed this, but if I did, I apologize. Are there specific examples of other school districts of comparable size that are using this model, and do you have examples of the savings that they have experienced, or have you not gone that in depth into the research?
Director Wass, we're going to defer this question to Mr. Newberger from Hayes Companies.
Sure. Director Voss, Director Bonds, Michael Newberger, Hayes Companies. A number of other school districts are doing on-site type clinics. Not a lot of them are doing the near-site clinic. So I don't really have a comparative point for you on that, in that they're doing more of the on-site clinic arrangement, as Vice President Miller and Director Falk had mentioned earlier. Some of your neighbors, such as Washoe School District and Racine School District, are also doing on-site clinics.
Okay, I got in the queue. I got Vice President Miller, Chair Bonds, and then so it's going to be Vice President Miller, and then myself. Then Director Woodward. Okay, Vice President Miller.
Thank you, Chair Bonds. I would ask that you look into an on-site clinic concept. I would ask that you do that. And I would ask that we consider the idea of experimenting with one clinic, not connected to copay or contributions to premiums, that on just as a competitive low cost with no copays, that we attempt to do that and look and see if there's any models like that around the country, not just locally, but also locally look at that to see if it's within that, if there is a practical way to look at that. Because I'm not going to support this in any way connected to copay or increased contributions to premiums.
All right, we've got Chair Bonds followed by Director Woodward.
Thank you, Director Phillip. Just a couple of questions to the administration. One, that saving is projected on a 10% usage, correct?
Director Barnes, member of the committee, that is correct. It's based on 10% utilization just from the doctor visits, and 5% from the urgent care and emergency.
And the reason I asked that question is because Director Voss said, are there ways to reduce the payment? So if that percentage increase, the payment could theoretically be reduced to cover that cost. But a more important question, what is the long-term intent of this proposal? Because when I look at $700,000 in a $1 billion budget, that's small. But what I want to ask is the intent to eventually get people to go a certain direction, or is the intent to help people stay healthy and reduce the need for the other thing? But it seems like there's something else that's missing in this discussion, so I just want those two questions answered.
Jim, where would we find more utilization? So we would start with 4 clinics in a near-site concept, and then where the utilizations are. And based on that, we can invest money into an on-site clinic. To build an on-site clinic and have capital outlay, and not knowing the utilization and not knowing how we would have employees use it, we would not find out initially what savings or what kind of migration we may see to these clinics. So in order to explore that, I think the step one we would like to do is a near-site clinic, and if we find in a particular geographic area that we can build an on-site clinic, we would probably explore that more. But once we build a clinic, it is hard to recoup back those capital outlay that we already have. So I would say give 2 to 3 years on a near-site clinic, and then explore more options into on-site clinic, which we started about 2 years ago.
Okay. Follow up. Thank you, Director Phillip. Let me ask the question once again, or I don't have the gavel, but I would respectfully ask that you ask the audience about the yellow so we can have this discussion.
Yes, Director, follow up.
Okay. The question. Let me ask the question a different way. How do you envision these clinics in 5 years and their impact on our current non-clinic insurance?
This clinic, what we would like to do is we would like to explore these options so we can engage our employees with a certain nurse practitioner. And that would help less utilization overall and have more healthier population. And this would have a better care. The whole purpose is to have, like Mr. Newberry mentioned before, to go to a doctor. We are hoping that the nurse practitioner will be able to spend more time and exploring different options for healthcare for the employees.
Thank you.
All right, we've got Director Woodward, followed by Director Falk.
Thank you. I would just like to ask a question. When you begin to look at the on-site clinic, and I notice you keep saying Milwaukee, and sis, is that just for Milwaukee?
Mr. Rio, Superintendent Driver.
Chairman Barnes, Director Woodward, and members of the committee, the clinic will be for all employees. The purpose we are trying to have the clinics more in Milwaukee because most of our employee database is still living in Milwaukee. And that is the reason we like to explore first within the city of Milwaukee.
We now we don't have a non-residential clause, so I'm asking what happens to the people that are working here that don't live in Milwaukee?
So, a good question, Director Woodward. The employees who do not live in the city of Milwaukee will still have access to this clinics in the city of Milwaukee. So they will still have access, and we are going to explore options based on where they are working and where they are living. So we will explore both the options.
Well, another question.
Follow, Director Woodward.
We're looking at costs, savings, and we started directly to the medical and benefits. Were there any other sources, any other things looked at that we should start cutting before getting to benefits for the employees?
Chair Bond, Director Woodward's members of the committee. There are a number of different things that we look at. when you start talking about the budgeting process every year. So this is the AFP committee, and so this is what we're bringing: benefits, the salaries, the on-site, near-site clinics. But then we also have a number of different things that we're doing in central office, looking at return on investment for a number of the programs that we have, and that's everything from interventions that we use, different programs, looking at utilization, and also looking at how we're funding it. So there's really a pretty wide spectrum of every single area that we have in our district in terms of looking at where are we making our investments, where's the return on investment, how is it impacting our young people, then what are those things that aren't working that we can eliminate. So this is a series of things that we're presenting to the board. This is not the only area where we're trying to look at savings. This really is a holistic approach.
Considering there's been a work and people doing the same thing, not good, so I just want to know if we could start at some of those things that are not beneficial, education, and academic.
When we have the principles in our SATs, part of the purpose of that is to rules and what happens part of the budget to be presented and walking through. So we have to look at we may as a our benefits. This really is looking at programs that we have. A number of programs that we have are whether it's through some of the $20 million annually from partners. We're bringing in 36. There's a number of other we've gone to help.
We would look at somewhere else before from our employees, cutting rate to the school where our students are, that starts in the classroom, and where our children, I hope we'll continue.
The house versus right now public schools, and I've tried to still they never got back. That really is doing both, and it's also with freighters. So since infancy is for in terms of that. I think in the state in-house clinic is, I would encourage the Mta Education Association, they feel about their was positive, but one of the in example.
Okay, so followed by some things aren't you out of here.
We understood before during Act 10. Posit this, and we know where the problem is. Now let me make this suggestion. If you want us to accept that out of here, get out. The last time in trying was it before the election. It meant that if I remember, the new gave the district $80 million. Now with our consultation, by a unilateral vision and dental coverage from. We have been and I've seen mine reduced by various to it. I'm getting there.
The next speaker, next. Get him out here. Security. Get him out here. Stick to the items. These items are Taylor. Once again, Ms. Taylor.
I want to say AYLOR. The information that we're primary doctor. They're always not and you go to urgent care 3 days. A couple months ago, I was hurting and I thought like that was urgent care. They told me to go home, ice it, and get better. I didn't have a big massage thinking anyone from going to your you've seen them, they know your people want to get medical attention. We're sick, we're well, whatever. That we're able to see a doctor, understand who we are, and know, understand budget and money. I want to see the very person that.
And I just want to be again option healthcare is not right now.
Vice President,
like it that if there's a connection to copay or increases, if that's
Vice President Miller, is that
because I be looked at. So I think Mr. Parikh maybe we could go over them. I'd like to.
Madam.
Should I copy the motion correctly? The motion is to allow to explore the option with at a low or zero copay.
Aye.
Chair, to ask the board or I would like certain situation here. I'm going to vote against copay increases here. What? Mr. sees that.
Okay.
Be looking at for the rest of the, I would like to submit a substitute, accept this report and come back.
Okay.
Just report.
Well, so we have to withdraw the motion.
Members of the committee, that is for this body, the motion to accept
the election for clarity.
To offer long-term disability as an employee voluntary option instead of a board-paid benefit. If approved, approximate savings for FY19 for a 6-month period would be $8.5 million, and for a 12-month period would be $17.1 million. I will turn it over now to Mr. Parikh and to Mr. Newberger, who are going to walk through the presentation. Thank you.
Thank you, Dr. Dawar. Chairman Barnes, members of the committee, Himanshu Parikh, Chief Human Resource Officer. In looking at the options to meet the proposed budget parameters provided by Milwaukee Board of School Directors, we have explored the options of benefit changes and estimated savings that could potentially fund the proposed salary increases to all employees and provide a salary structure for the educational assistants and the teachers unit. With a projected budget gap and the direction that everything is on the table, the administration has begun to look at options to meet this request. Estimated savings due to the benefit changes effective January 1, 2019 have been provided by Hayes Companies, who will do the presentation at a later time today. Administration has also reviewed the legal ramifications of the proposed spousal carve-out with the City Attorney, Ms. Ellen Tangen, and Bureau Vetter Attorney Matt Flannery. We have Ms. Ellen Tangen here, available for any questions that the board may have. And at this time, I would like to request Mr. Michael Newberger from Hayes Companies to provide the presentation. Thank you.
Mr. Newberger.
Thank you, Director Bonds and the committee. What I'd like to walk through today are the items that Mr. Parikh mentioned earlier, the first being the spousal carve-out option. In an effort to control rising... Michael Newberger. Sorry about that. In an effort to control rising healthcare costs, an increasing number of employers are adopting various eligibility rules that limit or exclude benefits for spouses of employees who have access to health insurance from the spouse's own employer. Statistics and surveys show that the percent of employers who are implementing these types of programs is increasing every year, and at this point in time, through a Mercer survey, shows that 25% of large employers have implemented these types of programs. Specifically, these programs would involve either a spousal carve-out, where if that spouse does have coverage available through their own employer, they would be carved out of the plan and moved over onto that spouse's plan, or that spouse's employer's plan, and not be eligible for the MPS plan, or a spousal surcharge, which is designed to where if, again, the spouse has coverage available to them through their employer, they can either move to their employer's plan or continue to stay on the MPS plan but pay a surcharge to stay on that plan. The intent of this program is to, if we were to implement this type of program, employees would be asked, those employees with spouses on the plan would be asked to complete an affidavit asking, does your spouse have other coverage available to them through their own employer? If yes, they then would be given a choice, or actually MPS would be determining whether or not they want to have the spousal carve-out program implemented or the spousal surcharge program implemented. So they are two distinct different programs. But basically they would be then asked to either remove their spouse from the MPS coverage, or they'd ask that spouse, if they stay on the MPS plan, to pay that spousal surcharge. That amount would be determined at a future date. As we discussed earlier, this concept was reviewed by city attorney and then also external attorney, and I'll let them address that if there are questions to that. We did do an analysis on the full carve-out option, which is listed up there. Again, hard to read those numbers, so I will walk you through that. Initially, what we did was take a look at the spouses who are on the MPS plan and bucketed them based upon their age. So you can see that there are actually 4 columns up there. The last column is a total column. But essentially, we're looking at spouses who are aged between 20 and 34, then spouses who are aged 35 to 54, and then spouses over age 55. I'll explain later as to why we bucketed them into these age categories. Essentially what we're looking at then is the number of spouses on the plan average number of spouses on the plan between 7/1 of 16 through 6/30 of 17. We're then estimating or looking at the percent of spouses with MPS as an employer. So in other words, if the spouse and the employee are working for MPS, they would not be included in this type of program because, again, they're both employees of MPS. So we wanted to eliminate those people from our calculations. So we got that information directly from MPS, and we have the various percentages listed there in that second row. We then basically do the math through to look at row 1 multiplied by row 2. The next row then looks at row 4, estimated percent of spouses with other employment and health insurance opportunities. This is an estimate here, but based upon our own experience in working with other employers who have implemented these types of programs, and then just overall judgment as to how many people we believe would have other coverage available to them. So if you walk through the columns, you can see for those individuals who are aged 20 to 34, the estimate is 60% of those individuals would be working with another employer. The spouse would be working with another employer, and they would have coverage available to them. If you are age 35 to 54, the estimate is also 60% would be in that category. Individuals who are a little bit older, age 55 plus, the thought is that not many of them may be working, so therefore the percentage is 10%. Again, you do the math on that and you get spouses eligible and working at 1,692 as far as the total column in that row. Then what we do is we bring in the average annual cost of a spouse, and we get that directly from United Healthcare, and we multiply that average cost by those employees who would be carved out of the plan. You work through that math and you get the estimated annual savings with the carve-out, and you can see the various columns that total up to approximately $10.4 million. Then we include an adjustment factor for these numbers, and that's twofold. One is because when you have these types of programs, the average utilization of spouses who remain on the plan, on average, are typically higher. So we want to account for that in our numbers. But then also we wanted to have a margin factor because we didn't want to overestimate or overstate the potential savings for this type of carve-out. So it's a combination of those two things that make up that margin number. Again, you apply the math and you get the estimated annual savings, if you go to the extreme right-hand column under total, of $7.91 million. Okay. The next area I'd like to go into is the plan design changes. And this mirrors what we had talked about earlier in the near-site clinic presentation. For the office visit copay, if we were to increase that primary care physician copay from $20 to $35 and increase the specialist copay from $35 to $50, the estimated annual savings is $3.8 million. If we were to increase the urgent care copayment from $35 to $50, the estimated annual savings would be $96,000. And then if we were to increase the emergency room copays from $150 for the PPO plan and from $125 for the EPO plan to a $175 copay for both plans, that estimated savings is $383,000. If you add up those three components, the total is $4.294 million. Employee contributions is another area where we could potentially look to make adjustments. We have two options to review here. For those of you who aren't aware, if you look at that first table, you can see that there are 4 salary bands, and that is based upon how much or what percentage individuals would pay for coverage. So we have our 3 plans listed there, the PPO plan, the EPO plan, and the high deductible health plan. We list the current percentage that employees are paying, and then we have the recommended percentage. What we're recommending or suggesting in this option is only the PPO and the EPO plans would have their contributions adjusted. In other words, if you look at that high deductible health plan section, you can see that under current and recommended, those percentages are the exact same number throughout. So no changes for the high deductible health plan. But if we were to go back and look at the salary bands for the PPO and the EPO plan, I'm going to combine these two salary bands. So in other words, individuals who are making less than $25,000 and individuals who are making $25,000 to $50,000, they would see a 2% increase in their percentage that they're paying for both the PPO plan and the EPO plan. And then individuals who are making $50,000 to $75,000 and individuals making $75,000 and above, they would see a 3% increase in the PPO plan and the EPO plan. So essentially what we're doing is we're taking the individuals who make less than $50,000 and increasing their percentage by 2%. Individuals who are making more than $50,000, their employee percentage increases 3%. The total estimated savings for this is a $3.2 million savings, and the overall employee percentage is right around 12%, which was a number that we were trying to address. The percentage is actually 12.06%. So on average, the overall percentage that employees would be paying would be 12.06%. In the table down below, we list out some general information as far as the number of employees who are in the various salary bands, and then the savings that would be realized in those various salary bands. Again, you can see at the bottom, the number is 3.246 million, which matches the upper table up on top. So that is option number one that we're considering. The second option is on the next page, and in this example, we're actually looking at adding a new salary band. So the table up on top is set up the exact same way as the previous page. However, at the very bottom, we now have a new salary band. So instead of having $75,000 and above, we now have as the fourth band, $75,000 to $100,000. And then the new salary band is $100,000 and above. So the way we would set this up is we would, again, leave the high deductible health plan alone and not make any changes to that high deductible health plan. For the individuals who are making less than $25,000, for both the PPO and the EPO plan, there's no change in that percentage that they would pay. For individuals in the second salary band, $25,000 to $50,000, there'd be a 2% increase in their percentage that they're paying for both PPO and EPO. Individuals in the third band, $50,000 to $75,000, there'd be a 3% increase for the PPO plan and the EPO plan. And then for individuals in the $75,000 to $100,000, there'd be a 4% increase. Lastly, those people in that new category, the $100,000 and above, there'd be a 5% increase in what they're paying in their employee percentages for, again, both the PPO and the EPO plan. The total estimated savings for this option is $2.96 million. And as you can see over to the right of that section there, the average employee percentage is now at 11.85. Not exactly the 12% number, but close at 11.85%. Again, average employee contribution percentage. Down below, we break out again in that table below the number of employees in the various salary bands, and you can see we added that fifth salary band there, and then you can see again the variance or the savings, which totals that $2.96 million, which matches the table up on top.
Why do you give us health insurance? Crying out loud.
The next section is long-term disability, and the idea here is that currently MPS has an employer-paid long-term disability plan for all employees, and the idea would be to terminate the employer-paid plan, but then offer what we call a voluntary or an employee-paid long-term disability plan. Currently, MPS is paying approximately $1.989 million in annual premiums for this long-term disability plan. Right now, currently, as of March 1st, there are no employees currently receiving this LTD benefit. Historically, total benefits paid out from January 1 of 2017 through March 1st of 2018, there were 4 employees that received the benefit for a total benefit of $47,534. So not a lot of usage there with that plan. As an option, as I mentioned, we'd offer some type of voluntary plan or employee paid. In this example, we're noting that we would just simply duplicate or replicate the current LTD benefit plan design and allow employees to buy that on an individual basis. On the right-hand side in the green section, we have various options for what it would cost for individuals making $25,000, $50,000, or $75,000 annual salary. We have options to offer various other LTD plans on a voluntary basis, and we can review that in more detail if the committee requests that we proceed with this option. So in closing, the summary of the suggested changes would be listed on this final page here, and we're simply repeating those numbers that we went through earlier. The spousal carve-out, estimated annual savings of $7.9 million. The increase in the office visit copayment both for the primary care physician and the specialist, $3.8 million. The increase in the urgent care copayment from $35 to $50, the $96,000. The increase in the emergency room copayment to the $175 number would be, again, approximately $383,000. On the employee contribution side, we went with option 2, which is the option that introduces that new salary band of $100,000 and above. That savings, if you recall, was $2.967 million. We list out the long-term disability premiums that are paid on an annual basis, which is the $1.989 million. And if you total all of those up, it equals $17.163 million. If we were to implement these changes on January 1st, the fiscal year 18-19 savings, or 6 months of that savings, would be half that amount, or the $8.5 million number that we have listed there. That is our presentation. Thank you very much.
Well, thank you for the presentation. If my colleagues do not have any objection, I'm going to go to the speaker slips right away if my colleagues do not have any objection. And once again, I will ask the speakers to stick to the item because this information is too important, and I don't want any message from either side against laws during this presentation. So once again, I ask people to stick to the item. Okay, with that, I got 26 people that want to speak, and I got 139 people who do not want to speak but fill out a slip. So I'm going to first start off with Amanda McEnholm, Jesse Boiling, and Elizabeth Kosmach. Okay. So if I got all 3 speakers come up and state your name and spell your last name for the public record. And once again, please stay to the item or else I'm going to have to cut you off. Okay.
It's Amanda McElhone, MC, capital I-L-H-O-N-E. I want to discuss the disastrous idea of changing to our health care. I can't imagine what kind of financial ruin having our spouses on a different plan may be to a majority of teachers and assistants in this building. I can't wrap my head around having family insurance that covers children, but not a spouse. Where is the savings in that? When I first started in MPS, I remember sacrificing pay raises and many other things to maintain our health care and being excited when the Tommy Thompson QEI was gone, but it feels like we're back and worse. This proposal is a slap in the face to everyone. We've discussed year after year after year after year after year how we are going to attract and retain new and quality people. Let me rephrase that, quality people, not just bodies. This crap is bodies. Remember that you get what you pay for and you offer for benefits. Our kids deserve the best, and now it's your job to make sure that you support the best. And I got about 500 people behind me that are the best. Yes.
State your name and spell your last name for the public record.
It's Jesse Bowling. Last name is B-O-L-L-I-N-G. Proud graduate of Wilbur Wright Middle School in '95 and Bayview in '99, and I'm a Rufus King High School teacher at the moment. Teachers in this district are done having administrative directives and the board carve out what are really necessary benefits and salaries for the employees from an ever dwindling pool of financial resources for students. What the administration and the board does not understand and do not recognize that these agenda items, including this health care, do not deal with the long-term education of the students in MPS. We continue to receive thousands less per student as districts around us. We've seen since 2011, we have been cut by 258 per student. We have a long-term funding problem, not only with our salary increases that are coming next, but also this healthcare. We're going to see a revenue limit drop by $12.9 million. We're going to lose $6.4 million from the federal budget in the upcoming. We need a long-term solution. This community seems to be finding ways to find money for the Bucks, who we're partners with, by the way, okay? It's great having them in here, but we give $250 million to billionaire owners, and our school district is partnering with them.
Jesse, I want to have you come back to the item.
I will come back to the item.
Okay.
We have paid over $1 billion for Miller Park, and that tax is going to sunset in 2019. The board needs to stand with us. I know you cannot write legislation. You need to stand with us and put pressure on the political leaders of this state to get more funding into the school system. You cannot keep sitting here and accepting cut after cut after cut and just treat it as business as usual. Mr. Miller, Falk, I understand we're in a big position here. But just accepting a cut after another cut after another cut. 3 things on our health care are going to get cut. Salaries, you're telling us that we can get 2.13% increase, and that's going to come out of busing for our students at Rufus King High School. That is unacceptable. I actually want to give the money back.
Thank you. I got to go to the next speaker. Thank you.
Elizabeth Kosmach, K-O-S-M-A-C-H. Good evening. My name is Elizabeth Kosmach, and I am a proud MPS special education teacher of 5 years and a proud MTA member. I am here tonight to talk about how healthcare cuts would be detrimental to me and my life as an educator in MPS. On October 20th, 2011, my life changed when I was diagnosed with lupus, an autoimmune disease. When I got the diagnosis, I sat and cried. I remember I was so scared and thought, how was I going to make it? Now, 7 years later, 5 years into my teaching career, I still sit and cry about how I'm going to survive physically and how will I survive financially. I delay seeing my doctors as long as I can because I simply cannot afford it. If I don't get treatment for my lupus, I will become physically ill. Sometimes I cannot get out of bed because I'm in so much pain. I have no choice to see a doctor. Even for this cold, it will turn into pneumonia that will put me in the hospital with IVs and another cut more money I have to owe. I'm on several payment plans, and even though I'm a 27-year-old professional, I still have to ask my parents for help, for money just to survive. Unfortunately, having lupus requires me to see specialists every 4 to 6 weeks. Having a chronic illness means having more than one doctor. I have 5. If you increase my copays, I will be paying over $3,000 out of pocket a year just to step foot into my doctor's office. A doctor I need to see so I can come to work and teach my students. If you increase my out-of-pocket, I will have to get another job, which is basically impossible because I already have 3 on top of being an educator. I physically cannot do any more. I am tired. I come to work on days when I know I should be at home, but I only have a certain amount of sick time, and now MPS is proposing to cut that. When will it stop? I cannot sit back and let this board and administration do this to me, my colleagues, and to my students. No more. I didn't choose to have this disease, but it seems like MPS is punishing me for having lupus. We live in...
I gotta cut you off. I got a whole list. Thank you. Your time was up. Your time was up. Next speaker. I'm gonna tell y'all what's shameful.
Next speaker.
Jessica Butley, followed by Angela Harris and Laura Cook. Once again, Ms. Butley, when the red light come on, you gotta stop. So I'll give everybody else a chance to speak. Go ahead.
You need me to spell my name? So my name is Jessica Buckley, B-U-C-K-L-E-Y. Not only was I a student, I am a teacher, and I am a parent. I started in MPS, and I stayed in MPS. My son goes to MPS even though he could go anywhere else. My two youngest will go to MPS. I bought my house in Milwaukee so our taxes would support the district I have been part of for the last 26 years. From Alexander Mitchell to Lincoln Center of the Arts to the 2001 graduating class of Riverside High School to fieldwork to student teaching to a now 10-year career in MPS, I am and I always have been MPS proud. I delicately balance my career and family, dedicating 15 to 20 additional hours a week with no griping. But this proposal to have a spousal carve-out and to increase our payouts and to cut our sick time is where I have to pick my family over my career. You see, my son, he has autism, he has ADHD, he has epilepsy, he has therapy weekly, occupational therapy bi-weekly, med checks monthly, EEGs, sleep studies weekly or yearly, and medication monthly. That doesn't include any time that he's sick. His doctor bills and medication already exceed $300 a month. How could I possibly put my heart into my classroom, coach, tutor, support families, give my 200% if I have to work more hours at my 2 part-time jobs to make sure that his needs are met? The truth is, I can't, and I won't. I would be forced to find employment elsewhere for my son and for my family's sake, and I'm sure I'm one of many who feel that way. Please, board, I implore you to consider other alternatives so that I can continue to do what I love and stay in MPS.
Angela.
Ms. Harris, before you go, I want to call out the next few speakers, Laura Cook and Melissa Patterson. Go ahead, Angela Harris.
Angela Harris, Harris. I'm a proud MPS parent of 2 beautiful daughters, Zaire and Trinity, and a first-year kindergarten teacher at MLK Junior Elementary School. It has always been my dream to be a teacher for MPS, and after 10 years, I decided to leave my job at a corporate child care center, go back to school, and get my degree. I have never looked back and never regretted my decision for one day until today. As a new educator with young children, the constant threat of cuts leave me uncertain of my future within Milwaukee Public Schools. As a parent of both children at home and at school, my needs are often secondary, like my health. I haven't been to the doctor for 2 years. I can't afford the bill, and now I face an increase to the amount I already pay. I don't want a corporate modeled wellness site
clinic with nurse practitioners or a spousal surcharge. I want to be able to go to my own primary care physician under an affordable copay. But rather than go to the doctor, I will continue to buy snacks because computer-based interventions are extremely tough when my children are starving. I will continue to buy socks, underwear, extra clothes, and coats because progress monitoring is impossible when my students are worried about their clothes. I have dedicated myself to these students, never calling in sick, staying at school for hours after the day is done, and going home only to work more. Every year, the cost of living goes up. The cost of insurance goes up. Childcare goes up. And I'm being told there's no money for raises. How am I supposed to survive? I can't work 2 jobs. This is 2 jobs. I've seen progress in my students socially, emotionally. I've grown as an educator. I've always believed that MPS is where I'm supposed to be. Today, you're going to show me if it's where I'm meant to be. There's hope, though, because I'm a dedicated teacher in a room full of dedicated teachers. And we will not quit until we get the classrooms, time, healthcare, and raises we deserve. Until we reclaim everything Scott Walker took.
Okay, I got to let somebody else speak for those. Ms. Cook, followed by Melissa Patterson and Leanne Chappelle. Ms. Cook.
Can you spell my name? C-O-O-K. All right, I am a proud MPS graduate, MPS teacher. My mom was also an MPS teacher. She was your high school teacher, Mr. Bonds. Since Act 10, my take-home pay has taken a huge hit, but I've remained committed to MPS and my students. My daughter was diagnosed with epilepsy at age 5, and we make frequent visits to the doctor all the time. Access to quality health care, affordable health care is a basic need, and the proposed increase in copays and premiums is going to make it extremely difficult for my family. MPS's new approach to the so-called health care will destabilize the district and pose a threat to all education workers and their families. When the cost of health care prevents workers and their families from receiving care, you've gone too far. I know money is tight, but this is infuriating and it's insulting, especially after we've watched MPS find never-ending funds for school uniforms, expensive consultants, and backdoor raises for administrators. Find funding for students and education workers when it is time to find funding for students and education workers, there's never enough money. Budgets are about choices. Please choose MPS students and educators, and also remember that we vote.
Melissa Patterson, followed by Leanne Chappelle. Ms. Patterson.
Hi, my name is Melissa Patterson, P-A-T-T-E-R-S-O-N. I'm a parent of 2 students in MPS. MPS is the only district I've taught in. As a special ed teacher, I can go anywhere and be so much more appreciated by administration and parents. Yet I stay here. And I stay because I can't leave my students. If I leave, who will take care of them? My severely disabled students deserve someone who looks at them with hope, who sees the kid inside, who doesn't care about the disability, and treats them with respect. When I started teaching 13 years ago, I remember not really caring that we didn't get these huge raises. We had the insurance to back it up, and that was okay for me. But now that has all changed. And I understand that changes need to be made. I understand budgets. I get it. I have one in my house. I balance it. It works. You want us to help balance this? Ask us. Give us a seat at that table with an open mind instead of saying no to every option we try to give. I give and I give and I give everything I have every single day. And you take and you take and you take advantage of my kindness and my willingness to be a team player, doing what needs to be done because I know it needs to be done. And now you're planning to take my husband off my insurance so that it costs me more, and you want to charge me more for fewer services. I'm a germ magnet because of the population that I teach and the realities of my job. I give everything, and all I get in return is a sinus infection and a sick family. I don't know how much more I'm going to be able to give, so I hope the central office phones are worth it.
I have Leanne Chappelle, Ryan Thompson, and Maureen Kerrigan. If those three individuals in that order can come up. Once again, Leanne Chappelle, Ryan Thompson, and Maureen Kerrigan. If they're in the basement, when they come in, they can come up front. In the meantime, I want to go to Tiffany Lawson, followed by Terry Grogotsky. I hope that I pronounced that correctly. Which one are you? Oh, Ryan Thompson? Thank you, Ryan. Spell your last name for the public record.
Ryan Thompson, T-H-O-M-P.
Ryan, wait. I don't want to cheat you out your time, so wait till the light turn on.
Sorry.
Mr. Chair, the light turns on after they spell their name.
Okay. Right.
My name is Ryan Thompson, T-H-O-M-P-S-O-N. I've been an MPS for 9 years, going on 10 right now. When I started in 2009, I moved here from Illinois. I moved here because I love the city, and I moved here because I thought they respected educators in Wisconsin. Less than a year after I moved here, we had the Act 10 fight. I started in MPS making $37,000. I didn't pay anything in health and dental premiums. I didn't pay anything in pension contributions. That was take-home taxes, everything else. Now, after Act 10, our out-of-pocket maximum went from $500 to $5,000. That is a $4,500 pay cut. You might say, maybe not everyone hits that maximum every year. I have 3 children. I have a wife with some health issues. We hit that maximum every year. That's a $4,500 pay cut. In addition, my health insurance, my dental insurance, my pension contributions are now $255 per paycheck. Times that by 20. That is a $5,000 pay cut. It's ridiculous. I am hard to replace. I have a physics, a chemistry, and a biology license. If you choose to vote for the spousal carve-outs, that's an $8,000 pay cut for my family. That's how much it would cost my wife to pay for her insurance at her work. I can't stay here. And you guys, you're going to save $49,800, because that's my salary right now. I can't keep doing this. I want to, but I can't keep doing it. Please leave our spouses on our health care and find somewhere else to save that money. I know you can. Thank you very much.
All right, next in the queue we have Terry Brokowski, Christine Maller-Yatzhawk, and Matt Stark. Mary Collins as well. So we've got Terry Grahowski, Christine Mailer-Yatzhawk, Matt Stark, Mary Collins. All right, as those people are finding their way, we've got Chelsea Boyle, David Weingrod, Debbie A. Off of Waterford.
We got one coming.
Hi, my name is Debbie Schultz, S-C-H-U-L-Z. I understand that everybody has to take a cut. I understand that everybody has to pay their portion. But I'm here to tell you, as a para, I have been in this district for 20 years. My children beg me to leave and find a job where I can support myself as a single person. At 20 years of service and at 62 years old, I should not have to sit here and every day go home and wonder how am I going to put food in my own house and pay for medical bills. I sit here and I am appalled. The policy goes, if you put in a fair work day and you work hard and you should be paid and you should be taken care of. I don't know how you can go home and you can sleep at night knowing what you are doing to all of us. At my age, I should not have to be thinking of, can I retire? Can I take care of myself? Because on what I have and what you're giving me, I can't. I stay in this job because I want to make a difference. I want to teach the future of our city, of our country, the United States of America, how to be kind, how to be considerate, how to be able to read. Do you have any idea how many children I touch and I teach them and tell them that no matter if somebody is mean to you, to be kind to them, but I stand here in front of you where you are being mean to us.
All right, in the queue, we've got Terry Grokowski, Christine Mailer-Yatzak, Matt Stark, Mary Collins, Chelsea Boyle, David Weingrod. All right, so next is Amy Maziolko. Is Amy in here?
Amy Maziolko, M-I-Z-I-A-L-K-O. I'm going to speak to what these proposed healthcare cuts will mean to this district. I'm going to start by saying that numerous educators, parents, reporters, and community members have asked me about the possibility of educators going on strike. Sometimes a walkout doesn't look like a picket line. It looks like the hundreds of vacancies in our district that can't be filled. It looks like increasing numbers of teachers leaving in their first and second year. Healthcare cuts will mean veteran teachers deciding to leave the career they love because they can't take any more of the insanity and the nonsense wrought by over-testing of our students and this administration trapping teachers in endless staff meetings and professional development when they need to be lesson planning and tutoring students and collaborating with colleagues and talking to parents. Healthcare cuts look like unstaffed after-school programs because most educators are working second and third jobs in this district. Healthcare cuts will mean fewer and fewer experienced teachers in the classrooms because no one's going to put up with this. Every time a teacher leaves Milwaukee Public Schools, the students of that teacher lose ground. Our community loses ground. I've seen classrooms become revolving doors of inexperienced and overwhelmed teachers, giving way to subs, giving way to paraprofessionals pulled away from their work, or overloading other classrooms, and our kids deserve better. And the 600 people in this building tonight, in 3 overflow rooms, deserve better. Vote this down.
Did you already call these names? What is your name? Okay, once again, Terry, I can't pronounce it, capital GROCHOWSKI, Christine Mahler, Matt Stark, any of those individuals here? Okay, Mary Collins. Mary Collins. Okay, Chelsea Boyd and David Weingrove. Tyson Kortmeyer. Tyson. Okay. Tyson, can you spell your last name for the public record?
Yes, last name is Kuhrmeier, Kuhrmeier. I came tonight because of item 4, the idea of the spousal cutout, which I think is an immoral act. I imagine a spouse of an MPS employee, who works at Walmart or something and has cancer, and we are going to kick them off our insurance plan. That's an immoral act, and I can't stand by and watch that happen. And so I wrote something, and I wanted to share it with the board tonight. I said, I love MPS. We are a sanctuary district. We're one of the most diverse districts in the state. Black Lives Matter here. We are a family. I truly believe that everyone here tonight cares about MPS. This is why we need to save MPS. As the board describes it, it sounds like we're on the Titanic, a ship that cannot sustain itself. The state has imposed a tax levy. The state has refused to give us our fair share from revenue sharing. The state has set us up to fail, but we cannot fail. The talk needs to end. We are a family. It's time to put down our pens and pencils and grab our walking shoes. It's time to strike. And Dr. Driver, I hope you join us.
Okay, once again, I called 3 people. I don't know if they made up or if they're here. Leanne Chappelle, Maureen Kerrigan, and Tiffany Lawson. Okay, if those individuals aren't here, I'm back to the committee. What is the Director Phillips?
Thank you, Director Bonds. I appreciate everyone taking their time out tonight to share their strategy with experts by forming an advisory committee to include the following: board members, members of administration, school-based staff, parents and community members, and local and state leaders in healthcare. I think it's important to understand where we are in our budget, and if I could have somebody help pass out what I've drafted. And I don't want to villainize people that we have tasked to look for cuts, because all the things that directors have said about $38 million and that cliff are true. But it's difficult to make a cut to benefits when we don't see the entire budget. And not knowing where else this money could come from is really difficult to say that it's coming out of benefits for workers. I also hear that I really don't want any response, because I want us to keep going. I know a lot of us in this room have to go to work tomorrow morning, so I'll continue to try to be brief. But we are tasked with a difficult option, and I want to make sure that people like they are involved in this process, which is why it's important for me that we continue to work with the administration to find how we can reduce healthcare costs. If we can reduce healthcare costs, we can find ways to provide healthcare for people that are working full-time in this district. If we can reduce healthcare costs, we can find ways to bring money back into the school buildings. I am personally committed to spending every minute that I can trying to find ways along with this community, but I refuse to listen to people say that we aren't listening, because we are, and that is why I am here. That is why my colleagues are here in the administration, on the board. We're all on the same team. Anything that's proposed on this floor extends to everybody that works in this district. So I think that it's time for all of us to come together and find where we should cut from this budget. And as many people have alluded, to continue to advocate on state and federal levels to get the fair funding that we deserve. So I've given the motion to my colleague for review. I know that it was very verbose, and that is what I have.
Okay, before I continue with my colleagues, Kathy Geiger, what you called, and have a young lady, did you fill out a slip yet?
I did.
What's your name?
Mta Jenkins.
Oh. Yeah, she was in there.
Yeah, let me just pull it up. Okay, go ahead. What's Jenkins?
Mta Jenkins, Jenkins. Lots of cuts like these makes it really impossible for us to believe that we're supported and that you care about us, that you value us. If you listen to us, this never would have gotten this far. We need to know that you support us. We need to know that, because we have to get up every single day. We're the ones that the children's lives are touched by. So we need to know that we can work with you. Director Falk said, you know, we need your help. Well, let's make that a genuine request. If it's a sincere request, let's not let things get to this point. Talk to us long before this. You have heard the individuals speaking tonight, some pretty brilliant minds out there. I think we could bring something, if you genuinely let us come to the table and not be timed by a red, light, and could be turned away when someone says something that's offensive. Have you any idea how many offensive things we hear? So I would just like to tell you, in 2016, the U.S. Department of Education declared to keep our nation competitive and to keep the American dream of equal educational opportunity a reality, we need to give every measure of support to educators and to honor their experience, their expertise, and the decisions that affect their daily work. Do you want to work with us? Because we want to work with you. We truly believe we could make the true difference. We could help solve this problem. But you have to be willing to sit with us and truly listen to us. And there's no better time than the present. My husband said last night, they don't need to think outside the box. We need a new box.
Ms. Geiger.
Kath Geiger, Geiger. My first question is, how does this affect retirees? I know my copays will increase along with everyone else's, which I object to, especially being on a fixed income now. However, retirees are excluded in your calculations of the rise in employee contributions to insurance premiums. Just because we're excluded now, that doesn't give me any reassurance that it won't affect us in the future. Please keep retirees in mind for all of this. There's also a disclaimer on the spousal carve-out section, quote, "The percentages and estimates are a projection and not a guarantee of potential savings." This reminds me of the projection error I witnessed last fall at our budget meetings when we had the budget shortfall. I recall there was a 6 to 12% error in insurance projections. What are we supposed to believe, please? These numbers are not very clear, and it does not reflect the total picture of true costs. You need to think of the effect these increases in co-pays and emergency room visits will have on your employees. People will be disincentivized by high costs to go seek medical care that they need. They will put it off, and then you will end up with a sicker employee population, which will spike absences and require more substitutes that you don't have now.
Okay, that was the last speaker. Well, I'm back at the committee. Who's next? Director Falk, we already had Director Phillips on. Director Falk.
Thank you. The gentleman that talked about the fact of Act 10 in terms of what it did to health care, in terms of now you're paying more into your health care. In fact, in the past we could argue that in some respects you might have been paying little or nothing with the exception of some co-pays. So you understand, this is not just an NPS problem, this is a statewide problem right now, and I think you need to do that. Right now, there's a blue ribbon commission on school funding, and one of the people who's chairing it is Luther Olson, a state senator, Republican. There was a hearing recently with two small districts, River Valley and Potosi, that spoke at that, and they're talking about these issues of health care and funding and everything else right now. Right now, school districts across the state that are losing students are all in trouble. So the idea of, if you want to go on strike, don't march around this building, march in Madison, and get the people from all those small districts that are in the same situation. Because we don't have the money.
Okay, anyone else?
Just one thing I want to say, when there was the protest regarding the Act 10 at the Capitol, I was there.
Okay, any additional comments by board members? Vice President Miller.
Yeah, I just want to say I support the motion by Director Phillips. Director Baez and I will be posing a similar proposal in the next meeting, which hopefully could start in the next hour. But I just want to say this idea of us really coming together and strategizing, because we all have to come together to solve this issue. This is not, for example, I looked at the facilities plan today, the report from the facilities plan, and it's devastating. It's devastating. So I really support the way you're approaching it, and we have to spend this next year doing some very serious collaboration.
Director Baez.
Chair Barnes, and members of the committee and colleagues, I support the idea. I think that there's any kinds of cuts to the health care of employees, as Director Phillips has suggested, and many people that spoke here today have. We are in danger of losing a lot of people, a lot of members of the family. So with that in mind, because the presentations that we have heard sort of like call on us to really look at it carefully and really raise a lot of questions about it. With all due respect to the efforts of the administration, it's, there are too many unknowns here in the air, okay? And because of all of that, we need a process, okay? That process, I would like to suggest, goes beyond healthcare. That process really requires that your idea of a committee go beyond the idea of looking at cuts in the area of healthcare and sort of like not increasing in any way the health, sort of like requirements of our family. Okay, so I would like to urge the committee that while you act on the items that you have before you, that you keep in mind that when we get to the second meeting, we have to have a discussion on where we're going to go as a district. But that discussion needs to also include, I think, the very fact that we need to find a way of resisting the onslaught that is coming down on public education. And we need to go at this as a unified front of people in this district, of us, because this is our family. And because this is our family, if we continue to allow what's happened is these suggested projections that seem to me to be contrary to what we need to do to save public education in this country.
Any other committee member like to speak, or anybody, Director Woodward, Ross, anybody else like to speak?
I'd just like to ask a question.
Okay, Director Woodward.
Okay. I would like to ask, we've been holding strategic planning and budget meetings. Had this proposed projection come before that committee at strategic planning and budgets prior to tonight? Was there any discussion with the board during this planning for this?
Superintendent Driver.
Healthcare event.
Chair Bonds, Director Woodward, members of the committee, we were given parameters from the board at the beginning of the strategic planning and budget process. Our first meeting was back in January, and I believe I'm looking at Director Falk to make sure I've got the dates right, but I believe it was January when we had
I'm
the...
not going to remember.
But it was in January, and so we were charged basically with the same list of parameters, trying to preserve class sizes, making sure that raises are built into the budget, and a number of other issues that we're trying to make sure that we can preserve in our budget. And so we've been charged with bringing forward a number of different proposals that can help us preserve those parameters. So that's what tonight is.
So you received it from the members of the board?
We've received direction from the board back in January. It was an outline of parameters, really, that were agreed to.
I missed some meetings due to an accident, so I didn't know where it came from. That's why.
Okay.
Okay.
I'm sorry, did you have follow?
That's okay, thank you.
Any additional comments or questions by committee members? If not, Madam Secretary, I think I'm sorry, Director Voss.
Thank you, Chair Bonds. One thing that I just wanted to mention, which really leapt out in the numbers, and this seems like a no-brainer to me, so I'm glad to see that Director Phillips has included this. The long-term disability plan that we've been buying is almost $2 million, and it's really only helped 4 people in the last year. And so that's a lot of money that we've been spending. So I'm glad to see, and I don't vote on this committee, but I'm glad to see that was addressed in this motion.
Okay, additional comments or questions? If not, Madam Secretary, please read back the motion and call the roll.
On Director Phillips' motion to approve the administration's recommendation to terminate MPS paid long-term disability plan, and that the board direct the administration to establish a strategy for lowering MPS's healthcare costs and improving the health and wellness of MPS employees with an emphasis on preventative care by developing and presenting to the board by the November 2018 board cycle, and that the innovative new methods for healthcare for MPS employees include strategies that reduce total healthcare costs at MPS by 10% without reducing benefits and without annual increases in employee premiums and cost sharing, i.e. deductibles, co-pays, co-insurance, etc., greater than the rate of inflation, and that the administration develop this new strategy with experts and by forming an advisory committee to include the following: board members, members of the administration, school-based staff, parents and community members, local and state leaders in healthcare reform.
On the motion, please call the roll.
On the motion as read, Director Falk.
Aye.
Director Miller.
Aye.
Director Phillips.
Aye.
Director Sane.
Aye.
Chair Bonds.
No.
That's 4 ayes, 1 no. The motion passes.
Madam Secretary, next item, please. Next item, please.
Item 5 is action on proposed salary changes for FY19. The recommendation is that the board approve the proposed salary changes for FY19 as outlined on page 12 of the attachments to this item.
Superintendent Driver.
Thank you, Chair Bonds, members of the committee. Before you is an item detailing proposed salary changes for FY19. These proposed actions include the following. I want to make sure I have everyone's attention, please. First, to continue the 5-year road to 15 until FY 2021 through 22. Second, to implement a 5, 7, or 10-year step schedule for educational assistance unit, including safety assistants, paraprofessionals, 6 hours, interpreters 1, 6 hours, interpreter 2, 6 hours, general education salary increase at a later date. Fourth, to provide a 2.13% salary increase to employees who are not covered under the first 3 items above, which include administrators, clerical staff, school bookkeepers, school engineers and boiler attendants, school psychologists, and support staff. I'm joined by Himanshu Parikh and Carol Edie, who can provide details via this next presentation and answer any questions that you might have. Thank you.
Chairman Bonds, members of the committee, Himanshu Parikh, Chief Human Resources Officer. For the committee's information, I would like to mention that the Wisconsin Department of Revenue has advised Wisconsin Employee Relations Commission, WERC, that the CPIU increase applicable to 1-year collective bargaining agreements with a term beginning July 1, 2018 is 2.1%. I would like to present the following salary potential increases. Road to 15 with an option of 1 year, 3 year, or stay the course of 5 years, which the board had approved on October 30th, 2017 during the budget cycle. Education assistant unit, we'd like to provide options of a 5-year schedule, 7-year schedule, and 10-year schedule. Teacher unit, we would like to recommend a 2.13% increase as provided by the CPI, with a structure to be determined at a later date. And all other employees, including clericals, administrators, bookkeepers, at 2.13% increase. And that the first slide of the presentation is for the Road to 15 for 1 year. Based on the data, we have employees as of January 26, 2018, when the data was collected, we had 909 employees who potentially receive less than $15 per hour. The annual salary of this employee is about $16.4 million. If we were to give them an increase so that they would get $15 per hour effective July 1, 2018, it would cost the district $2.37 million, which is an approximately 14.4% of their salary, and including the benefits of $356,346 for pension and FICA and Medicare, which are mandated benefits, for a total of $2.7 million increase. If you were to give the employees under the $15 per hour an increase based on 3 years, so that July 1, 2018, we would increase that on a road where the 3 years by FY 2020-21, they would reach the $15 mark. the increase would be for FY 18-19 would be $910,000, including the benefits of 15%. For FY 19-20, the increase would be about $910,000, and also for FY 2021. Based on the board approved on October 30, 2017 proposal of a 5-year road, which started on July 1, 2017, if we were to keep on course, the increase in, right now the count on this employee is about 880 employees, because that was the count as of October 26th when board approved the proposal. The 17-18 cost was about $644,000 with benefits. The 18-19 and the year thereafter would be about $640,000 up to FY 2021-22, and they all would be reaching 15 by that time. So it's pretty much 4 years left on the course that board adopted on October 2017. That would be the road to 15 options. Educational assistants, the demographics of the educational assistant unit. We have provided the positions that they employee groups, the positions that employees held in this group, the number of employees, the minimum of the range and the maximum of the range. And if we were to do a 5, 7, or a 10-year step, what would each step dollar amount would be? And that's what this represents on this slide. For example, an educational assistant or paraprofessional at 6 hours, which is 1,352 employees, the minimum of the range is $18,316. The maximum is $21,979. The 5-year step would be approximately $733. The 7-year step would be $523, and the 10-year step would be $366. The 5-year step cost for salary increase would be about $1.35 million. It is challenging under year 1 to put anyone on a step schedule because we have employees pretty much anywhere in the range. And in order to do onboarding to a step schedule, and as I said, it's challenging, what we would like to recommend is onboard everyone on a step schedule for year 1. And if the increase to there is less than 2.13%, so for example, if somebody is receiving an increase which is only like 1%, what I would recommend is give them a non-base building increase for the year 1 of onboarding of additional 1.13%. In that way, they all will receive at least 2.13% increase. In order to do that, there are some employees who might be receiving more than 2.13% increase because how they fall on the step schedule. And that's always going to happen when you're trying to put employees on a step schedule, but we like to have at least everyone make a minimum of 2.13% increase for the year FY 18-19. The base building onboarding increase on the step increases would be about $1,083,898. The non-base building increase is about $272,871 for a total increase in salary of $1,356,000. The benefits on that would be about $280,000 for a total of about $1.56 million in year 1. And these employees would reach the maximum of the scale by FY 2022-23. The 7-year step schedule will be in the same respect, but the FY 18-19 onboarding would cost $700,499. The non-base building would be about $222,000 and $961, and with benefits, the total cost is about $1,061,979 estimated. A 10-year step schedule with the onboarding cost of $573,989, the non-base building of $239,000, for a total increase of about $934,000. We want to be concerned about the compression in the schedules and the steps. So as you will see later on, the recommendation of the administration is doing a 7-year step schedule. Next, teacher salary increase concepts. we have recommended we at this point only provide 2.13% increase in the budget for a structure to be determined later on. The structure we are looking at in the concept-wise would be create a salary structure that is like lanes for teachers' bachelor's and master's degree. It includes an annual pay of PhD, which we currently have of $1,165, and then BBTS certification we have for $2,000 a year. Teacher incentive pay and hard-to-fill locations and subjects should be explored. Provide step increases, which needs to be approved by the board every year. Spread the steps, for example, it's just an example, or a 20-year step schedule. First step would be the place where the employee at the minimum of the range. The 2 to 5 steps, to 10 steps would have 25% of the salary spread, and the 11 to 20 steps would have about a 40% salary spread. What this would do is provide more salary in upfront to the teachers from years 2 to 5 and 6 to 10, and then have a steady increase after the years 11 to 20. And this would provide us with a lot of help with recruiting and retaining employees for the first 1 to 10 years. So at this time, the 2.13% increase for the entire teacher unit, we have approximately 4,965 employees under this unit. Annual salaries of about $300 million, and increase would cost about $6.4 million in salary increase, about $960,000 in benefits, for a total increase of about $7.4 million. We would like to collaborate with the teacher unit in the construction and seek board approval of the proposed salary structure and distribution of the 2.13%. Next salary increase would be for all the other employees. We're seeking also a 2.13% increase. Administrators, clericals, school bookkeepers, engineers, psychologists, and all the support staff. And again, teachers unit on this is also included at 2.13%. Like we said before, the total of 7,000 employees would cost about $413 million in salary. It would cost about $8.8 million for a benefit increase of about $1.3 million, for a total of $10.1 million with benefits increase, the cost of this increase. Proposed recommendations from the administration is Road to 15 to stay the course of the 5 years, which will be $558,440 approximately. Educational assistance, 7-year onboarding, $923,460. Other employees receiving 2.13% at about $8.8 million, for a total of $10.29 million. Benefits at 15% of $1.5 million, for a total of $11.8 million increase. Thank you. So that concludes the presentation. We have to answer any questions with Ms. Carol Edie, Senior Director of Benefits and Compensation.
Okay, thank you. If there's no objection to my colleagues, I'm going to go directly to the speaker slips. I have 126 people that do not want to speak, and I got 15 that people do want to speak. And once again, I ask people to stick to the times so everyone have opportunity to speak. Ryan Thompson, followed by Leanne Chappelle. Ryan Thompson, Leanne Chappelle. Melissa Patterson. Terry Krahowski, I think I messed up the name. Terry. Once again, I ask you to come out, speak, your last name and spell for public record.
I'm Melissa Patterson, P-A-T-T-E-R-S-O-N. 13 years ago, I had respect as a teacher. I had time to do what needed to be done without taking hours of work home each night. Piles and piles of paperwork. I planned parent events. Is this the list of new teacher duties? Because this doesn't leave very much time for teaching. But I do it because it's what needs to be done. I write grants, 9 funded Donors Choose projects this year alone, to get my kids what they need and what they deserve but I don't have the money to pay for it out of my pocket, and I'm certainly not being reimbursed. Next year, I'll also have to teach music. What qualifies me to do that? We keep saying the classroom is the most important place in the district, but we're constantly shown how this just isn't true. I've been waiting since January for the hole in my asbestos-tiled floor to be fixed. And I hear the heat will be taken care of sometime this summer. So I bring in clothes for the cold kids, and now I'm also Walmart. It seems like a fancy title at central office is what gets funded and what gets a raise. So I've been thinking of a reclassified title for days, but I can't think of something short enough to put on a nameplate that isn't a mile long, but accurately describes what I do all day and makes me important enough to be appreciated and fairly compensated. Maybe you'll have better luck.
Maureen Kerrigan, followed by Christine Meyer. Maureen, Christine. Okay. Debbie Ashaw. Kathy Geiger. State your name and spell your last name for the public record.
Debbie Schultz, S-C-H-U-L-Z.
Thank you.
I seem to be the only paraprofessional here this evening, but I am the one paraprofessional who in my building and by many other people that I know have been begged and asked to please get up and speak and represent us, because you do not seem to understand how important we are in this system. Whenever the responsibility comes up on who needs money and our teacher's going to go on strike or our teacher's not going to be there, well, I'm here to tell you, I have covered classes, taught classes, taken care of kids, and I do it with all of my heart. I do it every single day, and I have every other para who is standing behind me and teaches and fights and works with these children because we love them and we care about them. We're not here for the money, because that you're not giving to us. You went and our last raise was 28 cents. 28 cents over 4 years. You didn't go back and give us back pay on that. We got it just the 28 cents. So if you take it and you divide that, that is 7 cents for each year for an hour. I feel that I am way more better than 7 cents an hour. The sad part is when we see people at Target and Walmart and McDonald's who are now getting health benefits, who are making as much as we're making. If you take our salary and divide it by 40 hours a week, this is a slap in the face to us, totally. And I'm going to tell you right now, there is not one teacher here that will not stand up and tell you what a necessity we are, how grateful they are that we have us, and how every school needs us there to help cover classes, to cover for IEPs, to cover when they can't get a substitute teacher, where we don't get the pay that is needed to come back behind that. It may sound like we're making a lot of money an hour by giving us $18 an hour. I'm only getting 30 hours a week. So for 2 weeks, I'm taking home only 54 hours. I cannot collect any unemployment in summer, and getting a job is almost impossible. So I'm taking the little bit of salary I have and going over a 12 months period. So I really beg.
Thank you. Kathy Geiger. Kathy Geiger.
Kathy Geiger, substitute teacher, retired bilingual kindergarten teacher. Throughout the whole PowerPoint presentation of proposed salary change, there was not one mention of substitute teachers. Why are we not entitled to a 2.13 cost of living raise? We are always left out. In 2013, when I first started subbing, my hourly rate was $19.75. It's now $20.07, a whopping 32 cents an hour raise in 5 years. I implore you to add your substitute teachers into that equation for a salary increase. We have been neglected for too long. After we lost our contract in 2013, substitutes lost all their benefits and have been stagnated ever since. You have commissioned several studies and a task force to deal with the substitute shortage because I've been going to all these meetings. A salary increase for substitutes would affect all subs, which is sorely needed. And you will be finding out in your next 3 agenda items and reports on substitutes that another way to motivate substitutes to work more is by raising their hourly pay. Please pay attention to your own mandated studies and reports and relate them all together because it's all related. Thank you.
Mary Collins, followed by Amy, followed by Gretchen Wick. Mary Collins. Amy. Followed by Gretchen Wick. Amy, state your name and spell your last name for the record.
Amy Mizialko, Mizialko. The proposed salary changes in this item are a blatant bait and switch. Every single year, the educators of Milwaukee Public Schools have moved backwards in wages and benefits. This board should be racing to craft a budget that provides a full cost of living raise to every single employee and real movement on a salary schedule. It's not one or the other, it's both. Everyone here knows and understands that real wages will continue to stagnate if this board does not provide both a step and a raise. ESP 150 members, educational assistants and teachers really can't go on like this, and we have less and less to lose every year. The path to 15 is non-negotiable, and it's got to happen faster. A salary step schedule for ESP 150 workers and educational assistants is non-negotiable. One of my union sisters wrote to me last night. She has worked for the children of this district for 26 years. She is an educational assistant, and her gross adjusted income is $15,700. I asked her if she could come tonight. She said she is working a second and a third job tonight, and that she might be able to run over and stop in between them. I told her that we would stand in for her. And hundreds of other union sisters and brothers desperately want to be here tonight, but they can't because they're working second jobs. And to quote Angela Harris, this job is 2 jobs. MTEA members want a salary schedule back. This is what it looks like. But we want it for everybody, not just teachers. We want it for educational assistants, ESP 150 members. We know how to make it happen. Districts all around us have this, and across the state have one. Let's build it together for everyone.
I got Gretchen Wick, followed by Amanda Vogel and Melanie Brooks. Either one of those 3 individuals here? Okay. Rachel Schulater, Juan Herrera, and Enrique Moreno Lopez.
Amanda Vogel again, Vogel. You're worried about your budget. I get that. You're gonna save a lot of money when your teachers go to other districts. I came from a small town up north. My high school class was 25 kids. Everyone's shocked that I came to Milwaukee. I love my kids. I mean, 38 kids with, 32 desks is kind of rough, but they're my babies. I love my babies. But I have friends in 5 other districts throughout Wisconsin who send me openings every time there's one at their building. And I say, no, these are my kids. I'm meant to be here. If this is a job to you, that's fine. This is a lifestyle. We need to be able to live in that lifestyle. Pay everyone so we can stay, and you want to see graduation rates increase. You want to see our kids be successful. Well, have teachers. It's like Jordy Nelson just got released from the Packers because they can take that fund and buy more players and get them on the team. Well, retain your good players, you're going to see the outcome on the field. Keep your good teachers, you're going to see an outcome in the classroom. Guess what? More kids are leaving the district. Keep us in the classroom. Kids are going to come back to district. Enrollment's going to go up. Then there's money again. See how that kind of, balancing our own personal budgets. I can't buy the $7 jeans on sale because I need the $7, for milk and eggs. Figure it out. Sorry, thanks. Have a good night.
My name is Juan Herrera, Herrera. I'm a current South Division student and a senior. I'm the class of 2018. And I am I'm one of the people that is going to be the future of this country. Thankful for MPS, I see public schools as a success. For MPS, I'm going to be the first generation kid, well, not kid, but like first generation person in my family to go to college. I'm going to Colonel Stritch, and I'm going to get my license to become a teacher. And not only any kind of teacher. I don't want to be a private school teacher. I want to be a public school teacher. And it's because of public school teachers who have taught me all the things that I know now and have touched my heart to actually become an educator in the future. It's because of them that I decided to become a teacher. It was I've seen classes that have missing ceiling tiles. Sometimes there's holes in the wall. Plumbing in our school doesn't even work. Like, there's so many things in our school that could be so successful, but you guys don't put in the time, nor the money, nor the resources to it. Even these teachers need health care. They don't need cut from their health care. They need raise in their money. Thanks to governors like Scott Walker, things are getting more expensive, and we need a living wage. Everybody does. And I'm saying we, because I'm actually gonna be a public school teacher. I don't care what it takes. I'm gonna do it.
Hello, I'm Enrique Moreno Lopez, Moreno, and I actually signed in the paper for the previous act, so I guess this paper that I wrote has nothing to do with this. But I am a student in South Division. I am a senior, class of 2018. Juan is my classmate. We are here because we don't like what you guys are doing to our teachers. They are the backbone of MPS, just like the students are the backbone of MPS. If we don't have teachers, we don't have students. If we don't have students, we don't have MPS, and you guys don't have jobs. It's that simple. What you guys are doing is just sugarcoating this. I get it, you know, salary, healthcare, that's everybody's issue, that's their issue. But you're pushing away the teachers. If we don't have teachers here, we're not gonna have students here. You know what I'm saying? Because they're saying 5 years, there's not gonna be MPS if we keep going the same way. If you keep pushing the teachers, there's not gonna be MPS in a year. If you need an imagery, look at the tree behind you. That's MPS. That's all the teachers and all the students. We're a beautiful thing. What you guys are doing is cutting our water, cutting our nutrients, and cutting our roots, and we're gonna die. And that's not right. I don't know you personally. This is my first board meeting. And honestly, I'm glad I came here because now I can talk and you guys can listen to what I have to say. I see the way you're looking at me, and honestly, I like that chair, so you better watch out because I'm coming for that.
We got John Berger. John Berger. Gretchen Wick, did she ever come up? Melanie Brooks. Dosa Rosa. Okay.
My name is John Berger, B-E-R-G-E-R. I am the president-elect of PAMPS, so I represent the school psychologists, but tonight I'm speaking for myself. School psychologists are good with data, and when you give us $10 and take 20, that's not a raise in any way. That is actually going backwards, as my salary has every year. All you need to do is look at my bargaining unit and find out the quickest way to make a raise in this district is to leave. If you leave, go to West Milwaukee, go to Waukesha, go to Mequon, Thiensville, all the openings I just found on weekend for my job, I will likely make $6,000, $7,000, $8,000 more immediately. And under our current hiring practices, because there is such a shortage of school psychologists, next year you will hire me back at that rate. Because that's what you've done in my department, and that's what you continue to do. So when I have a young psychologist saying, why should I stay in MPS when I can make a lot more money somewhere else, be respected a lot better, not have all these cuts coming our way, I don't really know what to say to them. I'm not leaving because I love MPS. I'm not leaving because I have my own reasons for staying that have nothing to do with salary, but I don't know how to get any of them to stay, and I love it here. Thank you.
Are there anybody else whose name I called that have came back in the room? If not, I'm gonna go back to the committee committee members.
I have
Director Falk.
a question to the
I had put in my name, but I don't believe my name
What
is
was your
called.
name?
Aaron Taylor.
I didn't see it, but it's going out. We have you fill out a slip after you speak. Spell your last name for the record here.
T-A-Y. Priorities are to help our children. Do the people in central office raise our test scores? Do they give our students skills? Do they give our students the love that they need? Thank you.
Okay, is there anyone else whose name was called that might have just came in the room? Anyone else? Okay, if not, Director Falk.
Yeah, to the superintendent. First of all, I understand that your mandate's going to be not to cut health care, to increase wages, and of course later on, don't cut transportation, but give us a balanced budget. So how that's going to all happen, we'll have to see. My question on the health care,
I'm sorry, could you repeat what you said, please?
I'm saying, can you do that?
Can I do?
What, can you not cut health care, increase wages, not cut transportation, and give us a balanced budget?
The reality, Chair Bonds, Director Falk, members of the board, the reality is we have to look at a number of different options. We're not in a position anymore where we can I want us to think about this sort of two different ways. This isn't, we give you raises if we can raise your benefits. It's much more holistic. It's much more complex than this. We're looking at all of these different options because, quite frankly, we still have a $5 million gap to close. If we don't start to approve some portions of the different proposals that we're bringing, that's only going to grow. And so tonight, some of the other pieces that are coming at SPB, the transportation, some of the recommendations from the long-range facilities master plan, those are things we really need to consider. As I'm listening tonight and we're talking about how stretched we are, we don't have enough people, we've got a lot of subs, we need to right size. I mean, we just cannot avoid that. And I know, we've got a number of different proposals. It's everything from changing school start times. People don't want to do that. Changing calendars. People don't want to do that. Closing or merging schools. People don't want to do that. And we get to a place where we won't have a balanced budget if we don't do something. And so that's where all of these different ideas are coming to the table tonight.
I said that not as a criticism, but kind of to let you know that you're in a situation where you're trying to figure out how to balance this budget. My question on the salaries, and I'm a little confused. You're bringing this to us. Where's the negotiations on this one?
So negotiations for
with the salary, you're having salaries. There's a legal obligation to negotiate with the MTA. Where is the negotiations on this?
This meeting confer, right? Yeah, go ahead. Yeah.
Chairman Barnes, Director Falk, and members of the committee, Himanshu Puri, Chief Human Resources Officer. The CPI increase is what we are seeking board approval to negotiate. We are looking at a structure and not necessarily just the money. So
okay.
We would like to get first approval of the structure and the money so that we can go back to the negotiations and take some action based on that.
So what you're saying is that under the state law, we have an obligation to increase percentages on salary, but on the other things like steps and stuff like that, we don't have to negotiate. Is that what you're saying? I'm just trying to figure out. I'm a little confused at what's going on here from a negotiation standpoint.
Yes. Chairman Barnes, Director Falk, and members of the committee, what we are trying to do is put a structure to the salary, which we have not been able to since Act 10. So with, what we are bringing forward to the board is a salary structure for Road 215 educational unit, educator assistant units, I should say. Teachers, we still have to put a structure together, and we'd like to meet and confer with the teachers unit at this time. But for all, we would like to have a proposal in front to have a 2.13% increase for everyone. As we see, the increase for the Road 215 and the education assistance is greater than 2.13, so we are not able to negotiate with the unions those increases. We can only negotiate up to 2.13%.
So what you're asking for is kind of a recommendation of a meet and confer with the unions over this proposal in addition to the negotiations on the salary schedule. I'm just, this is a little confusing in my mind. I want to know what's going on here.
Director Barnes,
please take